the human body, but today we are speaking about the humerus. Of course, he's going to speak in a minute. From Argentina, we have a very good friend of mine, Dr. Diego Gomez. Dr. Diego, he's a shoulder and elbow surgeon from the city of Buenos Aires in Argentina. And he's a member not only of the Argentinian Shoulder and Elbow Society, but also a member of the Argentina Orthopedic Trauma Association, and he's very active and a brilliant surgeon in all of the fields of shoulder and elbow surgery. From Brazil, our place here, I have two special colleagues. First of all, I'm gonna, on the right side of me, Dr. Luis Fernando Coco. He's a good friend of mine. He's professor in the orthopedic trauma department of the Federal University of São Paulo, from which I come, and I spent 15 years of my life over there. And I have the big honor, the big pleasure to introduce to you this man, Dr. William Belangero, which is not only the president of Brazilian Orthopedic Trauma Association, but he is the inventor of anterior bridge plating. So it took me, in synthesis, 15 years of my life to get to this moment. So I really have to thank you all. I can guarantee to you all that we have many people seeing us. I have been receiving very positive expectations in my WhatsApp email last few days. And I just would like to mention one point before we start and you guys introduce yourselves. I have been spreading my project amongst a lot of physiotherapists in India too. So we have many physios here now, which is very, I would say, relevant. And I have a good friend in India, a very talented girl. She's named Dr. Devayani Thackeray from the city of Nagpur, and she has been helping me spreading my project amongst the physios universe. So Dr. Devayani Thackeray, thank you very much. We are counting on you for the next events. So having said that, I would just like you guys to start speaking. We will start with Dr. Shiva, but before that, Dr. Shiva, just say hello to everybody before we start, and I would like just the panelists to...
Hello. Thank you, Sergio, for having me here. Thank you very much.
Okay, Dr. Belangero, just say hello to everybody, please, because we have many people.
Hello, everybody. It's a pleasure to be here and to share our experience with you.
Okay,
Thank you very
Coco.
much.
Lovely. Dr. Coco.
Hello. Hi. Can you hear me?
Yes, but it's not, it's a little bit far away.
Really? So what about now? Better?
Okay, now you can speak.
So it was a pleasure to be here and share some experience with you. Sergio made all the introductions, so I'm ready to start.
Okay. So Diego, very nice to have you here, okay? And then we can start with Dr. Shiva. So Shiva, we are not listening to you. You can please share your screen.
Yes.
And then you can start.
Can you see my screen, Sergio?
Yes, yeah. You can start.
Okay. Thank you very much. Thank you, Sergio. This is my brief introduction, which already Sergio has given. Friends, Sergio is a good friend of India. He has come so many times to India, Nagpur, then Vijayawada, Chennai, you name the place he has visited, Agra. He even came to Sholapur when I was the president of the Maharashtra Orthopedic Association. You can see me in the front row along with Sergio and Vittori. He gave the prestigious oration in the Maharashtra Orthopedic State Conference on the anterior bridge plating, and he has propagated widely this technique in India. I have been meeting him at many platforms. I met him at CASCON, that is orthopedic meeting, arthroscopy meeting at Bangalore. Then I also met him in Nagpur during the 75th birthday of Dr. S.S. Babulkar, associated with a academic activity. Friends, these are all the members of India Earth Sergio will be knowing all of them by name, who all came together for a photo shoot when Sergio came to Sholapur. And thanks to Sergio for this wonderful efforts you have been taking to propagate this knowledge to all of us. Friends, if you read one of the sentence, I am the past president of nails. Probably only in India we have this association. Nowhere in the world we have an association only dealing with the interlocking surgery, because interlocking surgery comes under trauma in many of the part of the world. But in India, we have different problem that our stature of the patients are small, the canal is narrow. So our problems were different. Hence, we started this association way back in 2000. Now it is 21 years old association. Coming to my talk. Here is an example of a lower third humerus in a 18-year-old adult treated with a closed nailing. At 6 weeks, you can see beautiful consolidation with good function in the shoulder. I'm only intentionally showing the function of the shoulder because this is the one which is being blamed majority of the time by those who do plating. This is an advocate. He had a fractured humerus. See the incision, keyhole incision through which I have done the nailing. And you hardly can make out the incision when the patient came for implant removal. Almost always I do the implant removal, and this is the function about 5 years after the implant removal. Recently, in 4 or 5 years back, I have taken this clinical picture. Another patient, see the condition of the skin over the shoulder. He had a proximal humeral fracture. Again, I have treated with a proximal humerus nail with interlocking. And you can see the function. I normally start the shoulder function as early as possible because majority of the cases I operate under shoulder block, that is the Bayer's block. So the patient will not have pain in the initial post-operative period for 1 to 2 days. That time I mobilize them and they will get extremely good function at the end of the treatment. See, after the fracture is consolidated, see the function of the shoulder. Again, as I said earlier, I intend to remove all my implants which I have put them. Earlier, I was doing nailing only with 1 screw above and 1 screw below, but now I feel that 1 screw above, 1 screw below may cause some torsional problem, especially if the nail size is thinner than the canal size. So I have switched over to 2 screw system, 2 proximally and 2 screws distally. This is a case, so the whole video is available on YouTube, 1 hour video, the surgery and the implant removal videos are available. Again, this is after the implant removal, after beautiful consolidation. See the function of the shoulder. So this is after the implants have been removed, these pictures have been taken. You can hardly make out the incision. With this small 1 incision, I have been able to do the proximal locking and distal locking in the distal part. So 2 screws could be put just by retracting the small incision of 5 to 10 millimeter. Again, as I said, this whole video is available on the YouTube. You can search for that and you can get them. This is an interesting case. A fractured shaft humerus came to me almost about 7 or 8 days down the line. He had consulted so many people at different cities before coming to me. This was the wound which precluded the earlier surgeons to do a plating which was advised to him. See at the elbow, the bad skin, see at the shoulder. So this is on table. The very next day I took the patient for the surgery. This is the shoulder. I wrapped it up totally with a sterile drape. And my technique I'll be showing in detail later, but normally what I do is I pass a 1.5 millimeter guide wire. Over that I pass a cannulated drill bit, then take out the guide wire and pass the guide wire for reaming. Once the guide wire goes across the fracture site, I ream them properly canal, then I insert the nail and do the distal locking first, extract the nail to compact the fracture. As you can see in this case, the fracture has been compacted. Then I will go ahead and do the proximal locking. And when I do the proximal locking, I always see that the nail is well buried, at least about 5 to 7 millimeter underneath the bone. See, at the end of the surgery, 2 small incision for proximal locking. This is the 8 millimeter incision for the nail to be inserted. This is the immediate post-operative picture in the same patient. And this is on 3rd day when I took the patient for dressing. The wounds have started healing. This is on 3rd day the picture. You can see the wounds where I have put the stitches. Then at 10th day, when the patient came for stitch removal, this was the condition, and I did the stitch removal on 10th day. This is at 1.5 months. This is at 3 months. When he came for 3rd month follow-up, this is the function he had got. He had some pain at the fracture site. So I advised him, because I was not happy with this picture. So advised him PRP injection. PRP is platelet-rich plasma injection. And he agreed, and he came after a month. At 4 months, I injected the PRP at the site. It was more on the medial side. You can see the bone more on the lateral side, but it was less on the medial side. So I injected mainly the PRP more on the medial side. And this is just after a month. He was totally pain-free. This is 2 months after the injection. This is 8 months after the initial surgery. This is 1 year after the initial surgery. You can see beautifully the fracture has consolidated. And as I said earlier, I almost always remove my implants. I don't want them to be left in the body. So they don't have any work in the body. So I have removed these implants. This is the function after 1 month after the removal of the implant. Friends, I will make a bold statement here. I have been a nailer since beginning. I have been doing lambda-nodal wires between 89 to 96. Why not before 89? Because I was not involved in orthopedics. I was just a medical resident at that time. So I joined orthopedics in 89, and since then I have been using this similar to K-wires, but they're little more flexible and malleable. They're blunt at the tip. I use them for doing the humerus nailing. I also do extreme nailing for the distal third humeral fractures, thanks to Sergio. After interacting with him through Indo, I have done quite a few number of anterior bridge plating also with equally good results, even in all of them. So this is the effect Sergio has on me like a nailer. I am an ardent nailer, but definitely I do other type of surgeries. Friends, in general, humerus can be treated conservatively with a plaster, and that is the regular mode of treatment which we are doing. Thanks to lockdown, I had the opportunity to treat few cases with functional cast bracing as well as humerus cast. This is a joke about the humerus fracture. As long as two ends of the fracture humerus are in one room and an orthopedic surgeon doesn't enter the room, the bones will unite. This is what everybody says. In general, if at all surgery is needed, plate and screw fixation is the established procedure, still carried out as a routine in many centers because of the problems of the interlocking. I have kept them in the inverted comma. They are extremely very, very important. That is the part of my talk. The problem with humerus interlocking nailing about that is not many articles have appeared in the journals. Many report more complications with nailing rather than plating. Overall, there is a feeling that plate fixation is far, far better than a nailing. My talk is to remove those myths. I shall not talk bad about plating to prove my point. I am an orthopedic surgeon, as Dr. Tanna says, and I also treat them with other modalities like plating, anterior bridge plate, and other methods when indicated. So let me talk about how to do a proper nailing rather than talking about bad things about the plate. This is a landmark article which reviewed many of the humerus fractures, and this came out in the JBJS. The complication he listed were interlocking nailing of humerus has been said to be the technically more demanding and having high rate of complication. These are some of his conclusions. High chances of iatrogenic radial nerve palsy, severe impingement at the shoulder, adhesive capsulitis or shoulder stiffness is a known phenomena. Intraoperative comminution happens at the fracture site. Non-union chances are very, very high. These are the complications he enumerated. Probably this is the paper which has done more damage to nailing than anything else. Friends, I believe that it's the technique. All surgical techniques are good if well executed, knowing the principle behind it. They will definitely end with good result. Aim of our surgery should be to avoid complications, as many are due to technical problem and not due to interlocking nailing per se. So that is the reason why I said let me talk more about how I do my surgery rather than anything else. You can see, in the proximal head, I insert a joystick K-wire. Percutaneously, I insert in the head. This is only to have a control over the rotation of the head. So this is how the K-wire, which is 2 or 3 millimeter, you can see I can rotate it by 90 degrees. So without changing the position of the C-arm, I can take AP and lateral picture of the proximal medullary canal of the humerus. That is the reason why I use this K-wire. This is a 1.5 millimeter K-wire, which is used for 6.5 millimeter cannulated screw. I pass it in the center of the proximal medullary canal and I confirm it both in AP and lateral picture. Then only I will drive it more distally. So I am confirming that my guide pin is at the junction of articular and non-articular portion. Now I am seeing that it is entering into the medullary canal. Then once that is confirmed, I take a small 8 millimeter incision, very small incision I take. Then up to the bone, I go with a hemostat artery forceps and open up in line with the fibers. This is very important. Open up in line with the medullary fibers of the rotator cuff. Then over the guide wire, I pass a 4 millimeter cannulated guide wire. See, I am doing to and fro motion, not drilling with a power drill, because that will be always too much motion. So this will not entangle the soft tissue. Then I will remove this guide wire and through the drill bit, I'll pass the long guide wire for reaming purpose. I am passing the long guide wire now. I will use the drill bit as a joystick to manipulate the proximal fragment. Assistant only gives traction. Assistant will not help in the reduction of the fracture. I have the control over the proximal fragment. I manipulate the joystick of the drill bit. Then I will pass the guide wire across into the distal fragment, which I can feel and also confirm under C-arm. Now the guide wire has gone across to the distal fragment. Now once the guide wire has gone across to the distal fragment, I enlarge the entry with 8 millimeter cannulated owl, which comes with the set. Again, you can see it's a to and fro motion. If you rotate it with a power drill, all the soft tissue will get entangled and they will get damaged. So by to and fro motion, I am going to make an entry, and once that is done, I always ream. There is no role of unreamed nailing. You have to ream to fit a thicker size nail, and here you can see both fingers of the assistant, they are stretching, and that will prevent the soft tissue to get entangled with the reamer. And also when you are going across the fracture site, reaming should not be done. So this is very, very important. Again, as I said earlier, the whole YouTube video of the whole surgery is available on the YouTube. Yeah, I would request you to go through this YouTube video and find out more about this case. Some of the important things are, you have to operate from the head end of the patient. So the C-arm comes from the opposite side, and both and AP lateral can be taken in the same C-arm position without moving the C-arm. As you can see, I normally pass a guide pin into the joystick into the proximal fragment. Assistant also will just give a traction from the distal end. Friends, big surgeon make big incision. Gone are the day. It's the era of keyhole surgery. If you make big incision just to see the rotator cuff and then make an entry, you will land in stiffness definitely. They take a lot of time to heal. Always better to go for a keyhole surgery. It's a big no-no for opening up the shoulder. As I said earlier, I pass a guide pin first. Once the guide pin is properly positioned, I take a small incision. Over the guide pin, I drill with a 4 millimeter cannulated reamer. Then I take out the guide pin, and through the guide cannulated drill bit, I pass the guide wire, reduce the fracture. See, confirm it AP and lateral. See that it is going properly in the center. As I said earlier, nowadays I am using a joystick so that my life and the surgery can be done quickly without changing the C-arm position, or the assistant need not have to rotate the arm. Even if the assistant rotates the arm, the rotation will happen at the fracture site. That's one of the reasons for the radial nerve palsy. So that can be also avoided. As I said earlier, I use the centering owl again with hand only and enlarge the entry site. always support the distal fragment with a small towel, because there is a small pillow between the shoulders. So the shoulder is elevated. So the elbow also should be elevated when you are doing surgery. Assistant should give gentle traction to avoid radial nerve palsy. And when you are manipulating the fracture, gentle manipulation is very, very important when you are passing the guide wire across the distal fragment. Better is used the drill bit only as a joystick. As you can see in this case, I'm using the drill bit itself as a joystick and passing across the distal fragment. Excessive traction and using the tool, again a big no-no. They are all not required. Always a gentle traction just to distract the fracture site, few millimeter, not more than that. Then you get the guide wire across into the distal fragment. Then always ream. Reaming is to fit a thicker nail, which increases the contact, it decreases the working length, so that will be much more stronger. Always use a reamer. Coming to the reaming principle, reaming is done to fit a thicker and stronger nail. Better to be done with a flexible powered reamer rather than straight reamers. Always start with the smallest reamer. I normally start with 5 or 5.5 millimeters reamer. Then I gradually end up reaming up to 8.5 or 9 millimeter. Always ream over a guide wire, because if by chance the reamer breaks, then you can take it out. When using a detachable reamer, you have to use a beaded guide wire. That has to be kept in mind. Run the reamer only when there is resistance. Otherwise, just with the hand, you can push the reamer across the fracture site. Do not ream across the fracture site. Again, it might cause the entanglement of the radial nerve, especially if the reduction is not proper. So never ream across the fracture site. You just push the reamer into the distal fragment. Control of the reamer should be in the hand of the surgeon. Why I am telling is, in India, we almost use, many of us use the Manman reamer, where the foot control is there. Though there is a hand piece, the control of the drilling is in the foot. So the foot control should be with the surgeon, not with the somebody else. When you are passing the nail, always keep a look at the fracture site. This was the case. I have passed the nail across the fracture site. Such a beautiful reduction done. But when I was further hammering, you can see the fracture was getting distracted. The reason is, friends, the humerus is slightly curved distally. Then, though you have done the reaming with a flexible reamer, when you pass the straight nail, the nail cannot negotiate this bend. So that when you hammer that, distraction will happen at the fracture site. So always keep a watch at the fracture site when you're reaming. In this case, I used a thinner nail and I could do the surgery. Again, fractures comminution is another thing which is blamed. Always see that the fracture is reduced before you hammer. This is one of my own case. 2005, I was operating. It ended in comminution, because you can see there is an angulation. This should have been avoided by taking one extra shot in the C-arm, and I should have aligned it properly and passed the nail. Again, your guide wire in the proximal canal should be in the center, both in AP and lateral. Here you can see it is eccentrically placed. What had happened, since it was eccentrically placed, the flexible guide wire could bend and go into the distal fragment. The flexible guide wire has gone and it has reamed. But when I pass the nail, you can see there is a iatrogenic comminution. So that is the reason why I'm insisting that your guide wire should be center both in AP and lateral. Even if you want to take the entry from the top, from the articular surface, especially in proximal humeral fractures, don't worry. Go and take an entry from the top in line with the center. Then use judiciously your C-arm. The C-arm can be kept in 9-inch mode, which doesn't show the distal locking properly. By making in 6-inch mode, the hole can be better seen. By making in 4.5-inch mode, it can be still zooming can be done. Always use a sharp K-wire, and because the humerus is distally triangular shape, it slips. So make with a small sharp K-wire a dent in the anterior cortex. Then you use a awl to, by to and fro motion, make a hole in the anterior cortex. Then you insert the K-wire rather than the drill bit. Because it's a small incision, you can do the drilling with a K-wire and pass the K-wire and drill the distal fragment. And I almost always do the anteroposterior locking, so I don't find any problem with the C-arm in the same position. After having done the distal locking, always extract the nail to compact the fracture site. This is how I normally extract the nail to compact the fracture site. I already done the distal locking. You can see one of the hand is pressing the shoulder, giving a counter support, and extraction is being carried out. That will compact the fracture. So this is the pre-operative picture. This is after compacting the fracture by few extraction after distal locking. You can see the fracture gap has been reduced. Again, in this case, again, this YouTube video is available of this patient. There was a gap here. After extracting the nail, the gap could be totally reduced to zero. So this is very, very important. And always there should be, the nail should be kept slightly underneath the bone. It should not cause impingement. So when you select the nail, your nail should be slightly shorter so that you should measure the gap at the fracture site, and extraction back. Even after extracting, the nail should not come out. That should be kept. And nowadays I use bone wax at the end of the surgery. I just apply little bone wax over this so that bone ingrowth will not happen at the end of the nail, and the nail extraction at a later date will be very, very easy for me. Friends, shoulder problems are enumerated. The main reason is too proud nail, which is the one which should be avoided. So after having done a surgery, you should encourage the patient to do passively movement within the next 24 hours. The patient is here, the patient is using a shoulder ladder technique to climb and do the abduction. After 10 days, just before the patient is discharged, you can see that before the stitches were removed, you can see that the patient is able to abduct actively. Again, this patient, you can see the incision passively with the help of other hand is lifting the operated limb. When he came for stitch removal, you can see the stitches are not yet removed. When he came for stitch removal, he is able to abduct it actively. So that is very, very important. Friends, regarding the radial nerve palsy, this is from the book AO Principles of Fracture Management. When patients present initially with a radial nerve deficit and a closed injury of the humerus, it is almost always a neuropraxia, and primary exploration of the nerve is not absolutely indicated. Over 95%, I reiterate, over 95% of the nerve, radial nerve injuries will recover spontaneously. So there is no necessity to go search for the nerve, see whether it is contused or not. You just can go ahead and do the nailing. Friends, but in case of secondary nerve palsy, then after you have done the surgery, patient had no nerve palsy earlier. If there is a palsy, then definitely it is something associated with a problem. You have to open and see the nerve. So this is very, very important. I might have treated at least in the last 20-25 years about 15 to 20 radial nerve palsies which were pre-operatively there. I have never had the problem. All of them have recovered in my cases. Practically speaking, if one does close procedure, there is no need to explore except to explain the patient the possibility of the recovery in time. You can tell them that it is going to take 3 weeks to 3 months time. We'll do the nerve conduction test. If it doesn't recover, then we can explore at a later date. Like that, you have to keep them informed and give a reassurance. If there is a requirement to do a open reduction and fix, even when there is no need to specifically look for the nerve. However, if the approach is such that one has to tackle the nerve, as in posterior approach, the nerve is identified and a neurolysis can be done and continuity of the nerve can be documented. But this does not in any way hasten the nerve recovery. This is what the textbook, AO textbook say. So this is one such case which I had operated in 1996, almost 25 years back. This patient had a segmental fracture. This is after the initial surgery. You can see the radial nerve splint we have given in the patient. When the patient came at 4 months, the patient had a total recovery of the radial nerve. This is another case. Again, you can see the patient was traveling on a motorcycle and the sari, that is the dress material, get caught in the wheel and she was thrown off, and there was a fracture of the humerus as well as radial nerve palsy. Again, I did the nailing and I have done the implant removal, as I said, and this is the clinical picture showing good radial nerve recovery. Friends, nailing doesn't tolerate gap at the fracture site. Unfortunately, humerus is a non-weight bearing bone. Unlike the lower limb bones, this distract the weight of the arm itself, distract the fracture site. So never ever get fracture site distraction. So this will act as a non-union machine. So gap at the fracture site. If there is a gap at the fracture site, how long to wait? This is a question. In a transverse fracture, persistent gap, non-weight bearing takes unusually long time if there is no problem. Allow all activity, it usually unites by 1 year. Friends, I'm telling this, interlocking nailing with a gap, normally it takes 1 year to show the union. Keep the patient informed to avoid apprehension. Otherwise, the patient will go to other doctor and somebody will do a bone grafting and take the credit for that thing. So you have to inform your thought process. This patient with so much of gap, you can see after 1 year, there was total consolidation without any intervention. Patient had no problem in between. The patient also had not come for follow-up in between to me. Probably if the patient had come in between, I would have taken a decision to do a bone grafting, but luckily he had no problem. So he came with a united one. This is an orthopedic surgeon. That was the time I was not doing even distal locking. I wanted to do all dynamic locking. I used to do only locking at one end. And I inserted a very thick 8 millimeter nail in that narrow medullary canal. Almost for 2 years, there was no fracture, didn't show any union. The person, orthopedic surgeon himself, he was doing all activity, including reaming with hand reaming using Kunsher reamers, and he never, after 1.5 years, he stopped taking X-rays. And then I went behind him, asked him to get an X-ray, and after 10 years, he took an X-ray in 2013. You can see that the fracture had consolidated. So the fracture which had not healed for almost 1.5 years, over the time has healed. So seeing a X-ray union sometime in a nailing will be difficult. This is the same person, Dr. Ashok Poddar, on whom on the right arm I have operated. That's the same case I was talking. This is the X-ray of Dr. Ashok Poddar after 10 years after nailing. We didn't show union for the initial 1.5 years, showed union at a later date. So the lessons learned are, in transverse fractures, it takes unusually long time to unite, as the bone is not a weight-bearing bone. Wait if there are no symptoms, inform your thought process to the patient, reassure them, and so that they will wait along with you. Otherwise, they will go to somebody and get it operated. As I said earlier, before doing humerus nailing, I was doing laminar wiring. I have good series of laminar united, and many of them were not uniting also. They have seen many of them non-union. So when Elizarov came to picture, I started putting a frame above and below. In the proximal fragment, one frame, and a distal fragment, one frame, and I used to compress and got the union. Similarly, few of the non-union cases of humerus also, I have taken the same step, and I have done with one ring with 2 wires above and below. I have compressed the fracture. This will give stability. It will use compression. It will also act as interlocking because the wires are there. It will prevent rotation. All this has given me good union. Unfortunately, almost 7-8 cases I had done. All of the pictures, images I lost due to a virus in my laptop at the time. So this was a case of non-union. Already 3 times operated by so many other surgeons. I was invited to operate this patient. I did a nailing. Again, you can see I used a Elizarov frame above and below to compress the fracture. The fracture, which had not healed for almost 4 years, united after this surgery of mine. Friends, complications. Definitely plating, well done plating complications are less compared to nailing. But they're not, the difference is not too much, because almost 10% of the cases, if they have got some minor complication, that is acceptable. To give an example, plate failure patient is like a heart attack. If a plate fails, the patient is incapacitated. The patient becomes disabled. They come and get the surgery done immediately. Whereas if the nail fails, the fracture, there is non-union, there is gap here, but patient can carry on all the day-to-day activity, so they postpone the surgery. It's like an osteoarthritis of the knee. When we advise TKR, HTO, they keep on postponing. Similarly, with a nail, the patient postpones the surgery. Here, this patient came only because there was a distal end fracture. But this patient, almost 10 years back, the nailing was done. There was a non-union. Patient had no problem in spite of the nail being so proud. So this is Dr. Muki's case, which he recently shared on WhatsApp. So friends, what I'm telling is, with a nail in situ, patient is not incapacitated. The patient is able to carry out day-to-day activity. So they keep on moving from one surgeon to other surgeon. They keep on taking second opinion, third opinion, nth opinion. That's why we feel that probably nailing has more complication than plating. There is nothing more. Plating is 5%, 4% complication, and nailing is 7% complication. This was not a properly done plating, and the plate failed. Phylos was used, again that failed. This was the time I came to the picture, even that phylos had broken and the screws had broken. So what I did a humerus nailing, augmentation plate, and bone grafting. So absolute stability, non-union requires absolute stability, which I gave by a augmentation plating. The left side is 4 months picture and the right side is 9 months picture. Beautiful consolidation happened without any problem. The fracture, which had not healed by 3 earlier surgeries, could be united with a nail. I don't advocate this as a method of the treatment, but it can be treated properly. Nailing should not be blamed for all the non-union. See, this is a very improperly done nailing. There is a thin nail, interlocking hole is at the fracture side, short nail which is not going to the distal fragment, proud nail, missed proximal fragment. This is going to bend, break. So you should not blame the interlocking for this. You have to blame the surgeon for having done this a substandard nailing. So I treated this patient with a thicker nail, reamed thicker nail, and this is subsequent follow-up. At 2.5 years when the patient came, you can see that beautifully the fracture had consolidated without any problem. So what I'm telling is, properly done nailing is more important. This is another interesting case. I want Sergio to be attentive. See, this patient was treated with an interlocking nail, such a proud nail. Patient had a lot of problem with the nail. So the surgeon decided to remove the nail. And this patient came after 1 year after the removal of the nail with a non-union. Pakka non-union, there was gap, there was a frank mobility at the fracture site. So this case, I treated with a plating and bone grafting. So as I said earlier, I'm not saying that I do only nailing. I also do plating. Within 3 months, the fracture consolidated. And see the clinical picture of the same patient, the entry site of the nail, you can see, which was so proud earlier. And these are the function of the patient after the fracture consolidated. See, Sergio, the shoulder abduction on the right side is practically full. There is no problem. In spite of the nail, which was so proud initially, the nail was removed only because too proud and it was giving trouble. So don't blame the nail for the shoulder problem. Many of the elderly people will have shoulder problem. They don't do active physiotherapy in the post-operative period. That could lead to stiffness. Or it could be due to the initial injury itself. See, this was a case of plating done elsewhere. The patient came to me for stitch removal and further follow-up. So this patient also has a stiffness of the shoulder. It could be due to the injury itself. So don't blame nail only for shoulder stiffness. This is what I want to tell. Another case of a humerus fracture, plating done. This patient came to me with a shoulder problem, young adult. I cannot say this is a degenerative cuff tear also. Young adult, it has to be the initial injury. When the bone has to break, it has to have some problem with the joint also. So never blame only nailing for the shoulder stiffness. Friends, removal is also very, very important. Just doing nailing is not that. This patient also had a crush injury of the hand, and this patient, after the nailing, only came after 2 years. He has never come to me for follow-up. So comfortable he was. So this crush injury I have treated with a external fixator. At 2 years when the patient came, he had a good function. See the incisions. He had multiple abrasions. You can see multiple CLWs which are sutured. So I couldn't have done plating in this case, definitely. Nailing I could do. Implant removal. Implant removal always again under CM. As I said earlier, I normally apply bone wax at the tip of the nail so that bone overgrowth will not happen. So when the patient comes for implant removal, getting that nail, entering into the nail by the conical bolt is very, very easy. a small incision is taken. Again, owl is passed because there is no bone growth over the end of the nail. The owl could be passed easily. Then I am passing the conical bolt. Once the conical bolt is passed, you can see that the conical bolt is not in line with the, you have to take picture in both AP and lateral picture. Once it is in line with the nail, then only tighten it. Then you extract the distal locking and proximal locking. Then you extract the nail again. So this is after the extraction. See the incision. With a small incision, you can extract, provided if you use CM judiciously. The distal locking, the screw had already come out, so I had to take this out. This is at the end of the, again, after the implant removal also, start the shoulder function as early as possible. And this is at the end. Lastly, extreme nailing, because I know my friend Sergio is going to show some cases, very distal fracture like this. So I also do extreme nailing in the very distal third. As long as 1 inch space is available, I'm comfortable. If 1 inch space is not available, only few centimeters are available and I'm not happy, what I'm going to do? This is a hybrid fixation I do. I don't advocate this as a general treatment. In the last 20 years, I might have done less than 10 cases only, just because external fixator along with internal fixator, there is high chances of pin track infection. So you have to take this not as a standard treatment. So this young engineering student wanted to attend the exam and the lab. So I used the external fixator as the interlocking hole were too distal and I was not, probably I couldn't have done the locking properly. Proximally through the jig only, I inserted through the hole in the nail, through the jig, I inserted the shank pin. This is after the fracture has consolidated, the patient had a beautiful outcome. What I normally do is another case. I normally insert a cap of the vial so that the spin and the shank pin movements will be stopped. That movement is the one which causes the infection. So proper skin care, pin track care should be taken. This again, this young boy, because of the comminution, I thought let me do a external fixator as a hybrid fixation. This is after the implants have been removed. Unfortunately, though clinically it was not very significant, you can see there is a varus happening at the fracture site, because in this problem is due to the nail enters the lateral condyle easily. So nowadays what I do is when I take this case, I see that I open up the olecranon fossa and push the nail in through the olecranon fossa, as you can see in this case. So the nail is passed through the olecranon fossa after opening up the fossa. So here you can see my guide wire is going to the lateral cortex. What I did was I used a straight trimmer, opened up the supracondylar olecranon fossa from the top. Then I passed a guide wire. Then I did the reaming. You can see it's in the center of the distal fragment. Then I have passed the nail and then I have applied the external fixator. So once you know the problem you are facing, you have to analyze your own problem. Then only you can get over that. So these are some of the subsequent pictures in the same patient. Such a distal third fracture with so much of comminution, I could get beautiful result in this patient. This patient, I couldn't get the clinical pictures, but I got his pictures of the implant removal. This is the proximal locking done with the shank pin. So there is no other incision. From the top, I have opened up and gradually I have taken out the canal. With a small incision, I was able to do just removal of the nail when it came, because fixator was removed at the end of 6 weeks itself. Friends, to conclude, humerus nailing is a very good method of treatment. Keyhole surgery is possible, not as bad as depicted in the literature. Complications are slightly higher when compared to plating, and it does not tolerate gap. That has to be taken care. Do it properly. You will never ever, you will not be happy with, by doing properly. So it will never disappoint you. Thank you very much. Thank you, Dr. Sergio. If there are any questions now, I am ready to take now.
So, Shiva, first of all, thank you a lot. It's beautiful to see a guy with a lot of experience. I would like to mention some topics before we discuss a little, I'm gonna change a little bit the dynamics because Dr. Coco, he has a fracture to operate, but he's gonna discuss a little bit of his cases before he leaves. We can do it and then we listen to Dr. Belangero and I talk in the end. But the thing is, the first thing I wanna mention before we talk a little is that the surgeon is the method. I learned that with Gilles Vauch. Gilles Vauch, the surgeon is the method. So when you master something, you can do a lot of, you can use it in a lot of different scenarios. The only issue that I keep on always on thinking when you, Shiva, shows this beautiful lecture that I have seen sometimes, and you always make it bigger and better, is the issues about removal of the implant in a blind way. So this is what really concerns me. I would like us to talk a little bit about it before Dr. Coco speaks. But Dr. Coco and Dr. Belangero, but especially Coco, because you have a lot of experience with nailing, and besides the issues on removal, any specific thing that you would like to mention about this beautiful lecture of Dr. Shiva, Dr. Coco?
Oh, can you hear me?
Yeah.
Yes.
All right. So it's a very good talk. And in my hands, I'm a big fan from humeral nail. I used to fix my fractures with this technique, and I have really good results. So it's a kind of situation that we can choose between nailing or not. But in the distal part of the humerus fracture, I really use plates. I mean,
okay.
How distal fracture, in my mind, plates are better results and easy to fix than in the middle shaft. So I don't want to change my mind to have to nail all fractures. I mean, okay. I can do both, and I prefer nailing, but this is not a situation that I have to nail in all the fractures.
Yes. No, you see, there are many ways to skin a cat. And one of the beauties of this topic is that we have different ways to get to a final good result. Dr. Belangero, he knows that. But still, well, I would like to talk a little bit about the rotator cuff. We could stay 2 hours only discussing this, but we don't have that time. But Dr. Belangero, I'm really interested in your thoughts, at least the most important things about Dr. Shiva's lecture, keeping in mind that we have hundreds, maybe thousands of young surgeons listening to us. I would love to hear you, sir.
Okay. Congratulations, Dr. Shiva, for your nice presentation. Very good cases. I think that you have surgeons that like more nail and surgeons that like more plating. No?
Sure.
This is an option for the surgeon sometimes. But you have some kind of fractures that you can put nail or plate. For example, mid-shaft fracture, humeral mid-shaft fracture, you can use nail or plate. I think that in the most proximal fractures, in humeral most proximal fractures, nailing has a little bit advantage for plating. No? But for the distal fracture, I think plate is best. Okay. In my opinion, no, I don't have experience with nailing because I use plating for all fractures that I've been treated, but I see in the literature that nail is coming, and the result when you compare nail with plate is almost the same. No, you have the same rate of consolidation, infection. It's almost the same. I think it's a very good option.
Yes.
Okay, lovely. And Dr. Coco, you know, as I am a shoulder surgeon who does a lot of shoulder and elbow trauma, I'm always thinking about rotator cuff. So, and Shiva knows that. So having said that, let me say what you, Coco, says about what you say about removal of the implant. This is something that, you know, I am always, I would say, shocked in a very positive way how Dr. Shiva takes the nail and he doesn't seize the cuff and the patients do absolutely fine. So this is something that I think, Shiva, that you do it in a very high level, and maybe that would not be, I would say, allow me to say this, advocated for all of the juniors to take the nail out without seeing the cuff, without your experience, because we know that rotator cuff is a fragile structure. So having said that, Dr. Shiva and Dr. Coco, any thoughts about strategies not to damage the cuff in removal? This is a key point, and I think it must be addressed, and Dr. Belangero is agreeing with me. So Shiva and Dr. Coco, your points about this exactly issue, which is very important.
See, in the shoulder, the fibers are in this line. So when I insert the K-wire, I take a small incision in line with the fibers and split open. I'm not taking the incision at 90 degrees to them. So I take the incision in line with the fibers. So I open up with the artery forceps. Probably that is one which is not damaging the rotator cuff. That's one. Second thing is, my incision is always 8 millimeter or less. If you see on an arthroscopy, there is a 8 millimeter rent. Do you stitch it? This is my question as an arthroscopy surgeon, shoulder surgeon. So you will also think that it will overlap and heal them properly. So a small incision over the rotator cuff is not going to do any damage. But most important thing I feel is doing the active exercises with the normal hand. They keep moving it, and almost always my anesthetist gives supraclavicular or cervical nerve block. So the patient will be pain-free almost for 24 to 48 hours. I get all the shoulder movements done in the post-operative period. So that could be the reason. Yeah.
Okay. Coco, your thoughts about removal. This is a key question.
All right. So I think to remove the nail sometimes is harder than put the nail. So I think the pitfall is preserve the rotator cuff insertion. The tendons are the problem, not the muscle. So that's making the entry point have to be in the center of the head, not in the great tuberosity. So the medial aspects of the rotator cuff is safe enough. You know, my master degree was evaluating what happened with people with antegrade nailing. So we have good results when the muscle are treated like a muscle, and the tendons have to be treated like tendon. So when you have the rotator cuff lesion, you have to stitch the tendons, not the muscle. So if you have a big hole, in my mind, you have to have a big incision and see what's going on in the rotator cuff. And if you have a good stitch, I mean, if you close the rotator cuff, we preserve the soft tissue and the bone. So my incision to put the nail and to remove the nail is more than 8 millimeters. So I really like to see what's going on in the subacromial aspects of the shoulder. So it makes me comfortable to really.
I think like that. So what is the size? So what's the size of your incision when you take the nail out? I just want to know, is 4 centimeters, 5 centimeters?
Yeah, between 3 and 5 centimeters.
Okay.
Things like that.
And you see the cuff, Dr. Coco.
And I touch the cuff. I can put my finger and be 100% sure there is no hole after put or remove the nail.
So having said that, because this is we have been discussing this for a lot of time and many years, but it's beautiful to show these different point of views in this topic. Diego, any clues about these nailing issues?
Yes, I think it was an amazing lecture. I want to congratulate Dr. Shiva. It's a huge experience he has. And a thing I want to say, as well as Coco said, is the entry point. I think that's fundamental. That's maybe my main concern nowadays when I use a nail. I think the techniques have changed a little bit, and
Yes.
we even have less damage if we use the center of the head as an entry point, and we can be as medial as possible to avoid having shoulder injuries after the surgery.
Okay.
I agree with that part. Even I am taking more medial entry nowadays from the top. Yeah.
Right.
Okay, so my last question, Shiva, with all of these concerns about entering in the middle of the head, I like it what Dr. Coco said. You think about a muscle as a muscle and a tendon as a tendon. It's not a cliche. It's a reality, okay? Not cliche, it's a big reality. So having said that, have you been changing your mind, Shiva, to enter more medial or not?
For proximal humeral fractures, I started taking the entry much more medially. Then I realized that the entry in line with the medullary canal makes our life much more easier because the nail can easily go. So nowadays, even for shaft fractures, I don't mind taking the entry from the center of the head.
Okay.
Yeah.
So see, just one thing. As Dr. Coco, he has a big fracture and he has to leave in 25 minutes. I'm just gonna change stuff for him to show us at least 1 or 2 cases before he leaves, and then we can go with Dr. Belangero. Just very fastly, Dr. Belangero, as you were mentioning that you like nails, especially when you go, I would say, more proximal. Any points about the entry point of the nail, Dr. Belangero? Anything to add about this? Because many people want to listen to you.
Yes, I'm referring about these new nails. I think the new nail, it's a straight nail. Then the entry point is in the center of the head.
Okay.
Not in the cuff, in the muscle. I like this nail. I don't like the other one. I like this one, this modern nail. I think this is a good nail. Okay.
And this is an important message for the nailers to I would say to properly do the entry point. This is something very important because, as I always say, whenever you put a synthesis, remember that one day you might have to remove it. So we have to think about removal in any part of the human body when we are doing something. I think this is very important. But I have one question, which is, I would say, a fantastic opportunity to say something to calm down a lot of Indian, even senior surgeons, which has been telling me for 15 years one problem that doesn't happen. I'm going to explain you why in my reality, but happens a lot in the Indian scenario, and Shiva will agree in a minute. The thing is, in these cases, clinical healing comes much before radiographical healing. This is my experience. And I guess that you, Dr. Belangero, you see the same, I'm quite sure.
Yes,
so
I see the same.
Yes, so just see the problem, and I want you, Dr. Belangero, to send a message to everybody who's watching. The thing is, in my public hospital, these patients, they are on my hand all of the time. They don't go for a second opinion or a third opinion. So, and they are, I would say, not exactly high-level patients from a very high socioeconomical point of view, in a point that they question less. They say, okay, Dr. Sergio, as long as you follow me, I'm doing good from a clinical point of view. So this is different from the office. So if it takes 11 months, 11 weeks or 16 weeks to have radiographical callus, the patient is happy from a clinical point of view, and that's it. He's not going to doctor, say bad things about the doctor, operated the patient with a good technique because there is no callus. about listening to this so many times, and they say, Sergio, I don't want to do anterior bridge plating because it's going to take 3 or 4 months to see callus on the x-rays, and many doctors will say bad things to care. They have to trust the principle because it's much less morbid.
Yes.
So Shiva, you know that these things happen in the scenario. So before you comment, Shiva, Dr. Belangero, if you agree with me, I guess you do, to send a message to many orthopedic surgeons in India that they just have to wait for callus to appear. And it's not because of that that they have to give up on doing this technique. If you can say this to them, believe me, I'm listening for 15 years, that would really, I would say, help me in convincing these surgeons, hundreds, that this is not a problem, this is not part of the game. If you can speak on this, I would be delighted, sir. And then, Eva. So you fully, we are not listening to you.
Dr. Belangero, we are waiting for your comments.
No, yes. So Belangero, I just want you, I just ask you to comment upon the delay on radiographical, because they fear this a lot.
Okay, I think the main message is when you do this kind of procedure, if you follow the technique correctly, you need to wait that the patient at beginning came without pain. The patient start the rehabilitation, start the elbow and shoulder movement without pain. I think this is the first important message for the young guys. You need to follow your patient, and the most important thing is without pain. Okay, this means that your osteosynthesis has enough stability, and the patient goes, oh, okay. Well, another important message, the callus formation. Okay, this occurs early if you have a multifragmentar fracture or a butterfly fragment, it's nice. But if you have a transverse fracture, it's a little bit later. Yes, but you need to trust in your technique. You need to trust in the biological procedure. This is a biological procedure. You have everything in favor of you and in favor for the patient because you do or you did a biological procedure. No, this is completely different from a mechanical idea, mechanical procedure. No, this is a biological procedure. You have to wait. You have to trust in your procedure. And you have to convince your patient that you are secure, you are trustful. If your patient see you, that you are trustful, the patient believes in you and follows you. This is the most important message that you need to pass for your patient, okay? And you need to follow your patient. You don't leave your patient alone. Don't leave your patient alone, please. Follow your patient, okay?
Yes.
I think this is the main message.
This is the message. This is the message. But Shiva, do you want to complement? Because this is so important for young surgeons to, once they have a good relation with the patient, everything is going to be okay. Good technique and good medical-patient relation. This is so important. It seems obvious, but the young patients, and they have to understand it. Having said that, Shiva, before Dr. Belangero comes for us to start finishing, I would like you to comment this, and as the president of the Indian Orthopedic Association, and as such an experienced nailer, to repeat the message to the young orthopedic surgeons. This is so important. I have a lovely opportunity to have you both to reinforce this. Dr. Belangero had, so now Shiva, please just speak a little about it.
Yes, definitely. I had 100% agree that we had to follow our own patients. Then only we will come to see the complications. Then we know what wrong has happened. To learn ourselves, we are doctors, we are learning every day. So only once we follow our patients regularly, then only we will learn by our own mistakes. That's one. Second thing is, you should inform the patient what is your thought process, so that patient also takes part in that. You inform that this is now whatever I am expecting is not happening. We will wait for 1 more month. Otherwise, we'll take the another road.
Sure.
So that he knows about that. Otherwise, what happens is, if the patient goes to some other doctor, they immediately see. It's always when we have operated, we think that we will unite. We will wait for more time. But when it is somebody else complication, we take a drastic decision very immediately. So somebody takes a drastic decision, and there will be misunderstanding between the patient and the doctor. So I always tell my patient that I am not seeing callus at present, but I'll expect this to happen. If this doesn't happen, if we have just if you have any complication, I'll treat it. But if you go to somebody, today itself, they'll say that he is going to do this. I tell that option also to the patient, saying that if you go to somebody, that option, whatever the plating, bone grafting, they will be telling, but I am waiting with you. Let's wait for some more time. That having the patient along with you, reassuring them is very, very important. Second,
yes, the final,
and the last part is, humerus is a non-weight bearing bone. We cannot extrapolate the results of a tibia nailing and femur nailing to the humerus. So in tibia and femur, we can do dynamic locking, allow the patient to walk so that the fracture collapses and comes nearer. But here, if I do a dynamic locking, the fracture due to gravity of the arm itself is going to get separated. So there is no question of dynamic locking in humerus. You have to do a static locking, compress whatever possible on table. And many a time, resorption at the fracture site might be extra in few % of the patient. There, they take lot amount of time. I showed the picture of a doctor, an orthopedic surgeon. It took 2 years or more than 2 years for the fracture to consolidate. A transverse fracture in the humerus, nailing requires at least 1 year to see the consolidation.
Okay.
So don't take a drastic decision of grafting or plating at 2 months, 3 months, 4 months when you don't see a callus. So wait. If the patient is not having pain, wait. It will get united. I have n number of cases to show. So I can show a lot of my own cases from whom I have learned. Thank you very much, Sergio. It was really wonderful. Yeah.
Before I finish, I just want to say that all of you, which are very experienced and represent a lot to international orthopedics, have highlighted to the young doctors that in this both techniques, which are biological, clinical healing precedes radiographical healing. This must be a message, and keep in good relation with your patient, and this is going to be everything. So see, I'm going to finish now because we are 3.5 hours, and I told Dr. Belangero that it would be. Yes, it was so nice to me. I am flattered, I am honored to have you both here. This is going to be in YouTube in a few days, and I'm going to send
already it is there.
So just before we finish, Dr. Belangero, your final words. Huh? Yes. So just for you, sir, who is so important, both of you in the international, just to say goodbye to the hundreds of people are saying before we finish, your just quick final words. First, Dr. Belangero, and then my good friend Shiva.
Okay. It was a very pleasure time. It's very nice. I'm very happy.
Good.
Very beautiful cases, very beautiful conferences. I like to see you, and I like to see the friends from India. Okay, I have to say thank you for this opportunity to Sergio, and maybe we can meet again
Sure.
in another activities.
I am counting on you, sir.
In our activities.
Yes.
Okay.
Okay. Thank you very much, Shiva.
Okay.
Thank you very much.
Okay, Shiva.
And
lovely.
bye-bye.
Yes.
Okay, Shiva, just
Yes, I should thank Sergio and other panelists today, because I said that it is weekend. I was not free any of the weekend, and you could accommodate. I know it's a working day for all of you. It's a Tuesday morning. Now it is 11:30 in the morning at Brazil. I know. It
Sure.
was really wonderful to have listened to. I have heard Bellagio and through Sergio so many times, but it was really wonderful to hear you personally today, and I learned a lot. Thank you very much. And the orthopedic surgeons who have been watching, at present over 2,500 people are watching, and there will be many more who will see it recorded version through YouTube and other channels, and they will be all greatly benefited by your wide experience. Thank you very much.
thank you, Dr. Ashok. Thank you for the opportunity. Do you want to say anything before we finish?
I think it was a fantastic webinar, and especially I believe all the speakers enjoyed themselves. So that was the most important point. Presenting cases and discussing them, it was so much enjoyment for all four of you. So I think that was the best part of the webinar. Thanks very much for sharing your experience. Thanks.
So before I finish, thanks, Dr. Belangero. I'm counting on you for next events. Shiva is my good friend, so we are always together. Thanks, Ortho TV. And as we always say, namaste and namaskar. Okay?
Thank you.
Okay, thank you. See you later. Bye-bye. Bye-bye. Thank
See you. Bye-bye. Thank you very much.